Welcome everybody to Department of Internal Medicine Roy Benke Grand Rounds, another Thursday. We're always broadcasting now from the Medflix studios here, USF Health. So a reminder, guys, the next 3 weeks is gonna deviate from usual. So the next 3 weeks, we are going to be meeting at the Valdez Family Auditorium, which is the old McInnes Auditorium. That's the name a lot of us know. Same place, second floor, backside of TGH. We will be meeting there on Thursday the 8th, the 15th, and then we're going to switch it up to the Tuesday the 20th, where for those 3 weeks, we will be doing Chair of Internal Medicine candidate presentations. They will be CME generating. For those wondering, am I going to get CME out of that? So far, the first one is going to be CME generating. The candidates will present their vision of the Department of Internal Medicine, but we'll also have some of their work. And so that presentation of their work is what will get us the CME credit. And the first candidate will be next week is Dr. Dawood Darbar from the University of Illinois, Chicago. Again, folks, we want people there. We don't want an auditorium sitting empty. I sent an email last night where I really need the help of everyone to try to motivate each other to RSVP to go to this event. And we need you to RSVP because that's going to help us with the food count, which we are going to have food there. And also to be able to know about how many people are going to come. So that we wanted to place, if we know it's going to be about 100, 120, we want to try to encourage everybody not to sit all the way to the left and leave a whole gap on the right. So program directors, because I know a lot of you are on here, I need you to make that commitment that you're going to get your fellows and your residents there, and we'll take medical students RSVPing as well. If you know you're going to have your medical student, have them RSVP to that link that I sent you. Forward that link to those folks. I do ask for people to know, again, I'm going to make a sacrifice by coming down there on both Thursdays. And so I ask everybody to make a sacrifice to say, hey, we're going to start rounding a bit earlier, 45 minutes, an hour, whatever you feel your efficiency needs to get your butt to that auditorium. We'd like you there by about 11:45 so you can grab your food, take your seat, so we can get started on time. So again, please RSVP to Jen's email, to my email. Harry sent an email just a couple of days ago. Dr. Yusuf Ayad is going to send an email as well. We're going to keep hammering this because we need folks to be there. We need your input. We want to choose the chair who's right for us. We're going to want your feedback as to what you think of these folks as they make their presentations. So with that, we'll turn over to today's presentation. So we're very, very fortunate to have Dr. Charles Edwards, Chaz Edwards, come speak to us. Chaz graduated from the University of Florida, where he got his undergraduate degree and I believe his master's degree as well. Chaz, also at UF?
Actually, UT, University of
Tampa. UT, all right, very good. Master's at UT. So Chaz is a Tampa homegrown native, and he, after saying, yeah, I think I'm going to go into medicine, she switched gears to USF, where he completed medical school in the year 1998. I was fortunate to be in Chaz training years, so I was 1 year ahead of Chaz and had him as an intern a few days. And then actually Chaz was my first ever resident. He was on medical consults as chief resident at the VA when I started my run as attending here. Chaz went off to private practice after graduation, but returned to USF Health. And it's hard to believe it's Chaz, almost 20 years. Almost 20 years that Chaz has been back with us. He is the founder of our TGH Maine Hospital Medicine. For those who don't know, we didn't have a TGH Maine until about 2014. Chaz was the founder of that group under the leadership of Dr. Sinnott as chair at that time, who wanted to increase our hospitalist footprint. And Chaz stepped down a few years ago after really building an incredible program that has sustained, now under the leadership of Bobby Ledford. Chaz mentored Bobby, mentored Austin, and mentored all of the great folks we have there. So without further ado, Chaz Edwards going to present our grand rounds for this week titled The Impaired Physician. We'll turn it over to Chaz. Thanks, Chaz.
Wow, thanks, Joe. I appreciate that. And thanks to everybody that's here and that is out there somewhere watching a screen, perhaps. I'm going to try not to move around too much. It goes against my instincts. So if I wander out, somebody please tell me to kind of come back to the center. So the topic today is the impaired physician. And the learning objectives, I used action verbs as I was instructed to do. I learned all about. And recognize the incident, describe different types of impairments, look at risk factors, signs, symptoms, general approaches to treatment. That's a whole nother topic, so we won't go too much into that. Then I would like to explain the process by which the state of Florida manages what we would describe as an impaired physician. So why did I want to come up with this talk? Well, it probably began close to 2 years ago. A patient who was here at Tampa General that I became familiar with, 56-year-old male physician who presented with jaundice times one day. When asked him about how much he drank, he just said he drank a lot. Enough. On presentation, his labs were here. His bilirubin was 17. ACO2 were up a little bit. His coags were okay at that time. He was diagnosed with acute alcoholic hepatitis and admitted for treatment and observation. There's not really a lot of treatment for these patients. He was felt to be out of the window for steroids, which would be one thing you might consider. Day 4, his bilirubin was 34. INR and his creatinine are bumped. And if you calculate this thing by the little computers you have, the 3-month mortality is about 40%. He was actually offered to be considered to be worked up for transplant. These days, recent alcohol use or abuse is not necessarily a contraindication for transplant. When he was offered it, I said that I didn't want it because this was me. And I didn't want it for many reasons. One was I wasn't sure if I could stop drinking or not. And I didn't want him to waste a liver on me. So I was looking at maybe a coin flip of how it was going to turn out. So the coin flip worked out for me. I stayed in the hospital for a few more days. The billy kind of leveled out. I was discharged, went straight to rehab, and started a long journey that ended up where I am here today. I'm going to kind of describe that journey, to kind of describe the issue in general. I will let you know that for some miraculous reason, all of my liver enzymes are now normal. It is not a common thing to happen. I would like to pause and say that I am eternally grateful for the care that I got at this hospital, from the support I got from my colleagues. It was something else that day to call up Dr. Follett, somebody that I had trained and hired and mentored, and tell him what was going on. And it couldn't have been better. The support I got, not only from my colleagues, from the division, from the college, it really was amazing. And I am in forever debt to too many people to mention. So we'll talk more about my journey as we go along. Now we'll talk about the greater topic, types of impairment. So there's lots of types of impairment. I'm going to focus on the substance use disorders, drugs and alcohol. If I use just alcohol, it means drug and alcohol. But there's many more. There's psychiatric, emotional, physical impairment, fatigue, cognitive. And I think as we think about these different types of potential impairment, what's important to remember is that the presence of a disorder itself does not mean that a physician is impaired. Right? If you got diabetes, you're not impaired. If you're in a diabetic coma in the OR, you're probably impaired. So kind of like if you have a couple of glasses of wine on the weekend, you're not impaired, but take it forward. In terms of substances, just about any substance obviously can be abused by a physician. And remember, when I say physician, it's residents, it's medical students, it relates to everybody. Alcohol and opioids by far the two most common. I would have thought that maybe doctors didn't really abuse ketamine and crack and heroin, but you'd be surprised. I've gotten to know quite a few. And so pretty much anything's on the table. So how do you define impairment? It's not as straightforward as I might think or you might think. One of the things you could do would be something like what psychiatry does, DSM-5. What is, for example, alcohol? How do you define an alcohol use disorder? And you've got these 11 criteria. One of the difficult things that I think you'll recognize is that it's not always easy, clearly able to identify. First of all, you have to ask these patients these questions, and you have to get honest answers. And sometimes it's shades of gray. Sometimes it's not. So this could be one way to say, hey, somebody's got an alcohol use disorder, and that's an impaired physician. By the way, I did really good on this test. Yeah, I worked hard for it, and I got a good score. There are a couple of societies that put out definitions for impairment. American College of Physicians defines it as impairment interferes with the ability of a physician to carry out patient care responsibilities safely and effectively. It sounds good, and that's great. It's kind of not clear, and it leaves it up to interpretation. Similarly, the National Institutes of Health says one unable to fulfill professional and personal responsibilities because of psychiatric illness, alcoholism, or drug dependency. And the difficulty for me of actually being able to clearly define it is played out when you want to try to study it. Like when I'm going to try to talk about the incidence and outcomes, it's a really difficult thing to study because first of all, what's the incidence? Well, who knows? You know, how am I able to really define? Like if I want to study lung cancer, I do a biopsy of a piece of tissue and I look at it in a microscope and there, that's lung cancer. If I wanted to study impaired physicians, well, how do I really know? If I stumble into a workroom near the OR and there's an anesthesiologist shooting up fentanyl, that's an impaired physician. By the way, that happens a lot, actually. I know it's kind of cliche, but anesthesiology, for any students here going into it, pay attention to this lecture. So it's difficult to know the true incidence. If you're going to ask people about it, people lie, especially people that have a substance use disorder. If you really wanted to know, you got to do biological testing, blood or urine testing. You got to do it a lot on people that are willing to do it. So ultimately, you end up kind of really only studying people that officially get involved in programs like I went through. There was one big study, probably the best one known, that was done in 2012, a big survey of both general people and surgeons, and they kind of screened people using this audit questionnaire. The response rate was really low. It was less than 30%. But they kind of said that between 15 and 20% of patients would qualify as potentially having a problem based on the audit score. Overall, if you read people who write about this, it's generally felt to be equal to the general population, which is at some point in your career, maybe 10 to 15% of physicians would qualify as being impaired on some level. Risk factors. There's the general risk factors that could affect anybody. And as common as addiction is, and as much as we've tried to learn about it, there's a lot that's still unknown about it. Certainly there seems to be a genetic component to it, something at birth. And then there's external factors that could affect anybody. Certainly psychiatric, depression, severe anxiety, PTSD play a big role in people's problems, life circumstances, you know, trauma in your life, divorce, death of somebody, job problems. But there are specific physician-specific factors that may come into play that I think are interesting, that people have written about. One is that physicians tend to be arrogant and self-reliant, so they may think, I can handle this. Yes, I do this, and maybe most normal mortals can't handle it, but I can. Physicians may be prone to burnout which could lead to reliance if your coping mechanisms. Because at the end of the day, if you're abusing a substance, one of your issues is you're using them to cope with life. And if you're having a hard time in life coping, you may you fall into that trap. Interestingly, there's some suggestion that females are at higher risk. So I'll just leave that out there. Accessibility, physicians obviously probably have easier access to, especially drugs. And then there has been seen in certain specialties higher incidences. Anesthesiology, ER, clearly, based on what I've read and what I've experienced, are two of the higher ones. And interestingly enough, internal medicine is one of the lower ones. So how could we maybe detect it in somebody? That's one of the things I was always interested in once I kind of found myself going through this. Like, besides how did I end up there, but is there something that could have been done earlier? That could have been caught, that could have been recognized, maybe could have prevented me getting as far as I did. So there's personal issues. One of the problems with the personal issues from my standpoint is they're kind of vague, and they can be seen in lots of different things. Withdrawal from family and friends, increase in accidents, increase in medical problems, increased emotional problems, financial difficulties. These can be seen in lots of things. So these may not be a great indicator that somebody's got an impairment issue going on. Work-related symptoms, when I kind of ran across this list, it made a lot of sense to me. I recognized myself in here, certainly. So things like being late to appointments, not showing up to work as much, where are they? I can't find them. Unusual rounding times, either very early, very late. Increase in secrecy, patient complaints. Obviously, if somebody smells of alcohol or they're overtly intoxicated. These may be clues. Again, there's could be a lot of different things going on, but things to keep an eye out if you're trying to take care of your colleagues. Again, it's often difficult to detect. The signs can be subtle and often blamed on other causes. If somebody's suffering from it, they're not going to be open about it. And physicians in particular, their work will often be the last to suffer. You'll often see them maybe have family issues, other isolation issues, but they'll hang on to work as long as they can. So what do you do if you have concerns? If anybody has concerns themselves, and one of the things I would like to hope that maybe can come across in this talk is if there's somebody out there that's concerned about themselves, seek help. It's hard, I know it, and we'll talk about different ways you can maybe do it. There's the standard way anyone could seek help. You could talk to a friend, you could talk to a family member, ask for help. Go to your primary care doctor, go to a psychologist or a psychiatrist, go to a psychiatrist that's an addiction specialist. Google seeking help, and there's numerous treatment centers, and there's national foundations, there's 12-step programs. And I would say that we could discuss the merits of each one, but if you make an honest attempt to reach out for help, you will find a way if you're honestly interested in getting help. USF has a couple of pathways you can go through with an employee assistance program, a resident assistance program. There is a wellness committee here at TGH. Maybe we can do something to bolster that up. Dr. Abel, future chief staff. But obviously it's a huge issue for somebody with a problem, because there's a great reluctance to admit it for lots of different reasons. No one wants to admit that. There's denial. I ain't got a problem. And there's fear. Shoot, if I have a problem, what's going to happen? What's going to happen to my job? What's going to happen to my career? I'm never going to be able to drink again. So unfortunately, this doesn't happen enough. I think if I could reassure people that don't be worried about the stigma, because I haven't felt it. Maybe there's somebody out there that feels that way toward me. I haven't felt it yet. And so It's worked out okay for me so far. It hasn't in the long term affected my career. And in fact, my career is a whole lot better than it was a few years ago. So please, if it's an issue for you, don't let the stigma bother you. Handling concerns about a colleague. Here's where I must apologize. I've tried to make apologies. It's part of a 12-step process of making amends. And I've tried the best I could to the people I work with. Because people raised concerns with me over the years. And of course, I downplayed it, denied it. Was probably pretty good in some ways at handling it. And I've always tried to tell people, I hope that they don't blame themselves or feel bad about themselves, that they shouldn't have done more, because they did. They play no part in this. This was all me. So it can be difficult if you're concerned about a colleague. All I can say is bring it up to them. Be plain. Try not to be judgmental. Say, I'm here to help if you need help. If you really have concerns, you can bring it up with your supervisor, whoever that may be, whatever role you're in. You could bring it up with the people in your organization. If you're in a hospital, on the hospital staff, if you're within USF, someone with USF. And you can, as a physician, you have the opportunity to report somebody to the state. Now, we're going to talk about this in depth. So there's two ways to report people. You can report them to the Board of Medicine, or you can report them to the Physician Health Program here in the state of Florida, which is called Professional Resource Network, PRN. We're going to talk about this process. So ultimately, impaired physicians are handled by the Board of Medicine. They're the ones in charge of your license. And in general, they don't want to deal with it. They don't have to. So in general, if they're going to get a complaint or a concern, they want an outside entity to handle it. So they have, in Florida, we have what's called a professional health plan, a physician's healthcare plan. And ours is the Physicians Resource Network. We'll get back to that again. I mean, the treatment goals are, what they'll talk about is rehabilitate and reintegrate, right? So rehabilitate, essentially, as a physician, it means abstinence. The goal of alcoholism addiction is not always clear cut if you look at different people's opinions on it. Abstinence is probably the most agreed upon approach for somebody that's got a severe substance use disorder. And it's what's required if you're a physician, as far as they're going to monitor you. And we'll talk about the different ways that this is accomplished in the state, and then hopefully try to get somebody back to work so they can help be a productive healer again in society and give talks, I guess. So the general approach that physicians are going to go through involves these things. So potentially there's an initial step would be detox. Now, detox can either be done at a standalone center that does detox, or it can be at a rehabilitation center where your first few days will be spent in detox. Then you will go through a period of some type of rehabilitation. There's different types. There's residential, so you're somewhere where you stay, you're not allowed to leave. You get counseling every day, you get music therapy, other things. And there's a variety of types of residential treatment facilities, a variety of cost ranges and amenities. There's partial hospitalization, whereas you would get everything you would get in a residential treatment program, except you go home at night and sleep at home. And then there's various types of outpatient, IOP, intensive outpatient treatment, which is a little bit step back, where you're getting a lot of counseling sessions outpatient from different types of psychologists, addiction psychiatrists. In the state of Florida, you will be required to go through a 12-step program that fits your underlying substance disorder, which is generally either Alcoholics Anonymous or Narcotics Anonymous. Pharmacotherapy may or may not be used. In terms of alcoholism, there is some data. It's not the greatest, that naltrexone may be of benefit in the short term. So that may be something that is required by your treatment facility or offered. for other things, for opioid addiction, clearly it can play a big part of that. And then you get monitored by your PHP. So PHPs, this is a big issue because this is really how physicians are managed. Started in the 70s. They currently exist in 47 states and in DC. I don't know which 3 states don't have it. And their function is to kind of have the boards of medicine say, hey, here's this problem, physician. You guys handle it. And let us know when everything's okay. Or a lot of times you'll just end up in PRN here in the state of Florida and the board will never know about you, which is the best thing to happen. Do these things work? The short answer is they do work a lot better than your average treatment of a non-physician being treated for alcoholism or drug addiction. The studies are limited and they're small. There's some controversy about whether you should study, you're allowed to study physicians in the PHPs, whether when they agree to it, they are agreeing to allow to be studied. And that regardless, there have been some studies. There's 3 that I found here that are of fairly recent publication. And in general, the monitoring periods vary, but in general, about 3/4 of physicians, at least, at the end of the monitoring period, were abstinent and working, which is a phenomenally higher rate than the general public, where the treatment of alcoholism or drug addiction is probably less than 10% success. Why is that? There's a lot of theories. Probably because a lot of physicians with substance use disorder, its situational component is much higher than maybe the organic component. You know, they were higher functioning earlier on in life and then developed a bigger problem as opposed to developing a bigger problem early on in life. They're by their nature fairly motivated and hardworking and motivated. And if you can separate them and break them from the cycle, then they're better able to use those inner motivations and will. And they've got a lot to work for. You know, they're not usually as financially destitute as your average addict. And so they can see a light at the end of the tunnel better probably than a lot of other addicts. So PRN actually covers a whole lot of people in the state with substance use disorders that need a license of some type. I found it interesting. Fairly early on, I ran across a guy who I became friends with. He's a veterinarian. And I found it interesting that we were so concerned about pets in the state of Florida that we're going to make sure. I thought it was great. You know, this guy wasn't doing meth when he was treating his beagles, which is what he had been doing, but he was a great guy. You'll notice who's not on here is nurses. Nurses have their own PRN. It's called IPN. And from what I've heard from meeting nurses in their program, they're a lot tougher than the docs are. So, and I will say that as an industry, nurses have it tougher about getting back to work. There's a lot of places that won't hire nurses that have been through the process. So physicians are pretty fortunate, I would say. So PRN, the process, how do you get involved with PRN? Because, you know, when I was years ago, had some titles here in the medical staff, I would actually get involved with other physicians who had issues with drugs or alcohol and be involved in counseling them and being actually involved in deciding what to do with them. And we would occasionally send patients, docs to PRN. And I didn't even fully know what it meant. It's this big kind of bogeyman to me back then, PRN, oh God. So I would, hopefully maybe somebody will get a better understanding of what it is. So how do you come to the attention of PRN? Well, you can contact them yourself. You can say to yourself, man, I got a problem. I'm going to call PRN and see, like, throw myself on the mercy of the court, let them help me. You can get self-referred. They're forced, kind of like, hey, we're the medical staff at TGH. You've got a problem. You want to stay on medical staff here, you got to go to PRN. or you can be reported by somebody else. You can just get somebody, anyone can call and make a report. So what happens then? Well, whether you've contacted them yourself or somebody has contacted them about you, then they'll call you. They will have you get evaluated. Now, once you agree to get evaluated, you are in PRN, and you must abide by that evaluation. And this is where there's a little bit of controversy here in the state and across the nation about the overreaching power of these organizations. First of all, if you don't agree to get evaluated, you get reported to the state. If you come in and you get evaluated and you don't agree to follow their evaluation, you get reported to the state. So you're pretty much going to do whatever PRN tells you to do. And if you go get evaluated, it's been my experience, and this is another issue, you're going to get diagnosed with a substance use disorder, and you're going to go through the process. Now, having been through it and having seen other people in it, the majority of the people doctors that I've seen there probably deserve to be there and are benefiting from the system. Have I seen what I would consider some abuses? Yes. And that just happens because of the particular structure within our state. About the people that do the evaluations are also often the people that do the treatment. And once you're in treatment, they've got your license. And they will let you go when they say you're good to go. So that being said, look, I am grateful that this process worked, that PRN is there. They protect you from the board. As we talk more about the process with the monitoring, I like the fact that for the people that know that I'm in it, they don't have to worry about me, whether that, if I say that I'm sober, I can tell you I'm sober, because if I wasn't sober, I would be caught and I'd be out of here. So I like that as well. And I think that the majority of the physicians I've seen in it deserve to be there and are benefiting from the process and are getting results of positive treatment for a condition that is very difficult to treat. So like for me, I went to treatment first, and it was several months. And then as you're coming out, I actually wasn't in PRN yet because I checked myself into treatment. No one had reported me to PRN yet. Most people in treatment are already in PRN because they've been reported. But I then self-reported to PRN because I needed monitoring, and that's who does it in the state. So you get a contract. They'll rely on the recommendations from your treatment center. The contract is generally 5 years in length, and it involves drug monitoring, maybe pharmacotherapy, maybe psychiatric treatment if you have a coexisting diagnosis of what they feel requires psychiatric treatment. It requires attendance at a 12-step meeting of your choice or that suits you. And there's a weekly meeting, like for me, every Thursday morning at 8 o'clock online with a group of people. If anybody's curious, the drug testing, it's pretty good. If you drink or use, you're going to get caught. That's all I can say. You may get away with it one day, but you'll get caught. It's a combination of urine testing, blood testing, hair, nails, maybe breathalyzer. And by anyone that's curious, because there's various ways to test your blood and urine. Alcohol can be tested in the urine. There's two different types of urine tests. There's one that can catch you if you've done it the last day, one that can cut up to 3 days. If I want to look at alcohol in the blood, I get a PEF test that detects it up to 3 to 4 weeks if you're a regular drinker. And then hair, nails can go to 3 to 6 months. And by the way, you got to have a lot of hair to get a hair sample taken. So otherwise, you got to grow your nails out for like a month. Not that I would know that or anything. Here in the state, about 25% of physicians in the program will, at some point during those 5 years, fail the drug test. So what happens? They bring you in, they reevaluate you. Was it real? Was it not? There are false positives on drug tests, but they are rare. At the very least, you're going to be continued to go along, but your clock is probably going to reset, and it'll be 5 years from then. At most, you may be sent back to treatment. Keep in mind, there's a financial cost to this. I always like to tell people, so I was in the hospital a bit for my liver, but I was also in my hospital for a little bit while around that because I also happened to develop cholecystitis and cholangitis. And no one wanted to take my gallbladder out because my liver didn't work. And so all fine now, all good, physically well. But I had a big hospital bill. My hospital bill for about 3 weeks total was $580,000. We have Blue Cross. I have Blue Cross through USF. They allowed $280,000, and Blue Cross paid every penny of it. Rehab, Blue Cross doesn't pay anything. So I found that interesting. They didn't pay for rehab, but they paid for the complications of my drinking. So there is a cost to it. It can vary depending where you go. I will tell you that 3 months of rehabilitation is going to cost you at least $45,000, $50,000. Easily more than that, again, depending on where you end up going. PRN will cost you over the 5 years maybe $20,000. So this could easily cost you $100,000 cash. And then you got to add in lost wages. USF has a great program for me, I think, with after you've used your sick leave and your PTO, you got short-term disability. There's various ways where the loss of wages is a huge deal for me. But imagine if you're a physician in private practice, if you're out of work for 3, 4, 5 months, it's a huge deal. So there are a lot of financial considerations for this. To summarize, ACP put out a position paper in 2018. It's a nice position paper about impaired physician, and these are kind of their summaries. So 1, the professional duties of competence and self-regulation require physicians to recognize and address physician illness and impairment. So I like this statement because it kind of says, hey, look, if you're going to self-regulate it yourself, as a profession, then you have a duty to monitor and keep an eye on each other and make sure that physicians are behaving appropriately. 2, the distinction between functional impairment and potentially impairing illness should guide this process. And this doesn't really talk about substances, but I think one of the things that will come up a lot is age. It's been an issue here at Tampa General for a while. What do you do with the aging physician? Just because, and like our presidential election, just because somebody's 81 years old, are they fit to run the country? And so what you should do about that, and I think it's important, just because somebody's old doesn't mean they can't be a doctor, but they should be able to function. I like this measured thing about PHPs. Best practices for PHPs should be developed systematically, informed by available evidence and further research, which I take to mean how I feel about it. PHPs are a good thing, but they need to continue to evolve. And again, on the 4th, it's also about the PHPs, meet the goals of physician rehabilitation and reintegration in the context of standard ethics and safeguards, both for the patient's safety and physician's rights. And then 5th, general maintenance of physician wellness should be a priority. So that's pretty much my talk. I could talk about this stuff for a long time, both my personal journey and the subject in general. Again, I just can't thank the people that I know enough who've helped me get back to where I am today. Hopefully I can kind of pay it back a little bit with talks like this and other things going forward. What I would like to say is that if anyone has a concern about themselves or a loved one or a colleague, please don't hesitate to contact me. Completely confidential. Whatever somebody talks to me about will stay between me and you. Here's my 2 emails addressed. I was going to put my phone number up here. Then I realized these things get posted on YouTube. So not quite there yet, but most people have my phone number, can get it. So again, call me, text me anytime. And with that, I guess I'll end. And if anybody has any questions, I'd be happy to take them.
Well, thanks, Chaz. Just want to say, we've known each other, a long time, and it took a lot of courage to do this. So really want to say thank you for doing this. And just, that's why we all work together, is we all get to know each other and just get to know each other's, strengths and traits. And certainly today you've shown how courageous you are. So I really am, thank you for doing this, and very impressed with this presentation. And I told you it wouldn't last 15 to 20 minutes. I told you you have such good material. It will go a lot longer when you actually start going through it. And obviously we went to 40 minutes. Also, you were worried that there'd be 6 people here. So besides the great crowd that you have there, you had almost 90 people who jumped on. So you had a huge crowd, and I can hear your fannies there. So all excited. I do want to point out what you said and what I stated 2 weeks ago. You turned to USF Health and your colleagues when you needed help. I mentioned 2 weeks ago that my wife faced a life-threatening illness. I went to USF Health. We believe, for all the trainees here and young faculty, we believe in what we produce here. We definitely believe in the quality and believe in the people, as Chaz mentioned, the folks that we have trained and brought forward. So, and I mentioned at the beginning who Chaz has mentored, and as he mentioned, those are the people who helped him through this very difficult time. So thanks again, Chaz, and we'll open it up to any questions that you guys have on this very important topic. Please, I know we have some hands raised, so we'll go. Jen, I'll let you kind of, lead the traffic with the hands raised.
All right, we've got both Robert and Dennis led with questions. Robert, you want to go first?
It wasn't so much of a question, but I just want to share, I've known Chaz since I was a medical student, and he gave me my job and was my boss for a number of years. And it's been incredibly transformative in both our personal relationship and in the work situation, the journey that he's gone through. And in more than one time in the last year since he's gone through his program, I have taken over one of his patients, and they have shared that I've never had a doctor like that before. And we're just so proud of him, and we love him. And I would be remiss not to share that with you all.
Thanks, Bobby.
Thank you, Bobby. I think Dennis was next.
He wrote in the chat, the hospitals and other institutions allowed to screen for participation in PHP and deny privileges even if you are meeting goals. That's a question.
Are they?
Are they? Can they?
Not to my knowledge, no. Now, PHP is pretty good about being anonymous. They won't, again, the board doesn't even know that I'm in PHP. And when I was doing my credentialing, when I used to credential people here at the hospital, we never knew whether somebody was in PHP. And it's interesting. I'll just add that I try to get a lot more data from PHP, but I probably could have. But anyway, my understanding is right now there's probably in the high 300s of physicians in the program in the state, which is, my understanding, is about half of what it used to be about 10 years ago. And one of the reasons they feel is that, I don't know if you've been around a while, when you used to apply for a state medical license or reapply, they used to ask you questions about whether you've ever had a diagnosis of depression, anxiety, or received treatment for it. And they felt that was being used against physicians, and some physicians were being kind of railroaded into treatment in the PRN that didn't need to be. You'll notice those questions are no longer on the application reapplication. So, yeah, so no, that data is not mined by the application process at Tampa General.
I'll just say that the change to the
With the who?
In the state, we have a council of Florida medical school teams.
Medical schools.
And, yeah, and so we did a lot of talking.
Dr. Mai here was saying that the change in that application process, a lot of that came through the advocacy from the medical schools in the state.
All right, thanks, Cook, for adding that. Appreciate it.
I got a question here.
So, in situations where be it a learner is concerned about their attending, or like a junior attending is concerned about someone higher up, all the way up to chairman or whatever, what it would be sort of the best approach to either get that individual help or, you know, or like trying to get PHP or whatever to help them? What's the best way to do that?
It can be difficult. If you don't feel comfortable talking to that person yourself for whatever reason, maybe you're junior to them or in some other reason, my suggestion personally would be your options would be to talk to somebody above them, talk to another colleague and get their opinions, maybe, you know, maybe a different attending. And if you really feel uncomfortable making it known that it's you with the concern, and if you're really concerned that somebody has an issue, that is one of the reasons PRN is there. So, you know, you can use that. I will say, I'll just leave it at that.
Hey, Jen, anybody else?
We've got another question here.
Oh, one other here. Go ahead.
I wanted to piggyback off of that, and again, if you go to other institutions, I'm not speaking for other institutions, and Dr. Mai can correct me if she doesn't agree with what I'm about to say, but I think at the medical school level and at the GME level, when in doubt, come to people like the two of us. Because if you are seeing things, either one of two things is happening. Either you're seeing something that's not really there, or you're seeing something that is there. And if there is something there, other people are probably noticing the behavior. And we have ways of contacting supervisors and not necessarily saying to report it. So, you know, there are folks who are sort of out in the loop, but out of the loop, that you can come to, and we can sort of keep where it's coming from and dig around a little bit and see if there's an issue there.
Yeah, I would say, again, I would probably say try to keep PRN as a last resort. Usually these days there are other avenues to utilize, but certainly use those avenues if you've got a concern.
I would add on, you know, it's a requirement for us, like in terms of professional competence, right? We make sure that we're prepared here. People are part of our team, but so ready to like provide safe. It's so important that it is a common program requirement that we provide that education guys regarding screening tools, signs, so that you are self-aware, but also like thinking about your team members, and that we provide lots of opportunities for reporting. So on the GME website, there's lots of like reporting mechanisms. They are all anonymous. You don't have to like give me your name. We will then either look into it ourselves or send it to the right people in the institution. You can also do this in the hospital. If you're seeing a nurse or somebody else, you know, there's RL and any safety concerns, and these are safety concerns, right? Not just like concerns about the person, and I think first and foremost, of course, that's what we're thinking about, but also thinking about like our accountability of patients in our community, right? So you can, if you see somebody in the hospital, you can also report it through the hospital channels, whether you're at the VA, office, TGH, or, you know, you guys have my number and call me anytime.
Did you hear that, Joe?
Yeah, call Cook Mai anytime. No, we caught that cook, and thanks
her-
for that insight.
And her
That's very
phone
helpful.
number is 1-800 Dr. Boss.
No, we appreciate it. Really appreciate Dr. Mai's leadership in GME for a lot of difficult issues such as this one. So we are very fortunate. Anybody in the Chaz's fan group is dominating the questions. So over TV land, anybody in virtual land, any other final questions? Otherwise, Chaz was worried that it was going to be 10 or 15 minutes. We're at 50 minutes, so you've hit the block just like you were. So, but I want to say again, one final reminder for the internal medicine grand rounds next week. The chair candidates, we have received a ton of RSVPs just after my first announcement, so I'm going to try one more to see if we get a few more RSVPs. Again, McInnes Auditorium, now known as Valdez Family Auditorium, second floor, TGH in the back. Same place always been. RSVP, so you can get food. Wright's Gourmet will be the selection for food. So always good stuff from there. First chair candidate, Dr. Dawood Darbar from University of Illinois, Chicago. He's a cardiologist. That'll be followed by another one next week, and then one a little atypical on a Tuesday. Again, we will go over that next week. I'll be at TGH live next week. We will have a virtual component as well for those at Moffitt, VA, Health Park, Morsani, you can't make it here. Once again, thank you, Chaz, for this talk. I really appreciate it. Thank you.